And as Jackie said, my job today is to set the stage a little bit further for us. And I'm going to do that by talking about three main things. One is defining some terms for us, particularly around physical activity and exercise. So as we're talking about behavior change interventions, what are we asking people to do? I'll talk a little bit about the evidence for the effectiveness of exercise for OA, the reasons we think it's really critical to do these types of interventions, and then establishing the need for these behavior change interventions in osteoarthritis based on data regarding physical activity patterns of people with OA. So defining the terms a little bit, we often use a lot of these terms interchangeably, but I want to get a little bit more granular with us today. We talk about physical activity. We're usually talking in a very broad sense. It's often defined as something like this: any bodily movement that results in energy expenditure, categorized in domains that may include things like occupation, leisure, daily living, or active travel. And then under that, we have a more specific type, which we call exercise, typically defined as planned, structured, repetitive, and intentional movement intended to improve or maintain physical fitness. And then under that, we have some different types of exercise. The ones I'm listing here: land-based, water-based, aerobic, strength training, neuromuscular, exercise-based physical therapy. This is not an exhaustive list, but these are some that have been studied in the context of OA. And all of these have some evidence for showing benefit for people with OA. Okay, so this is not meant to say that one of these is our specific target. However, I do think it's important for us to all recognize that the behavioral interventions that we're going to be talking about need to clearly identify the target behavior for patients who we're working with, and then also an intensity and a dose that is sufficient to yield clinically meaningful improvements, right? So no matter which of these is the target, whether it is increasing overall lifestyle physical activity or something much more specific like regular strength training, what's the effective dose and how do we help people get there? So let me talk a little bit now about the evidence for exercise in osteoarthritis. There have been many, many studies. This is one of my favorite, a recent study that is a secondary analysis of other meta-analyses on exercise, particularly for knee osteoarthritis. And I've put up here in the box the conclusion of these authors. And just to note, this includes 42 studies and almost 7,000 patients going back to 1992. A main conclusion was that the effect estimate of exercise benefits for OA was significant in favor of exercise from the first study onwards. The estimate leveled out towards a standardized mean difference of about 0.5 since 2010 with a stable confidence interval. So therefore, the authors concluded that the benefit of exercise has really been clear since 1998, when several studies were showing consistent results. And then further from this study, conclusion that no additional study of exercise for knee OA, no matter how big it is, no matter how big the sample size, would be able to change the current conclusion that exercise is clearly clinically worthwhile, which is shown in this contour plot in the red area, to clearly not worthwhile, which would be shown in blue, but is not even on the contour plot. So again, I think this study is one of many clear pieces of evidence that exercise is a benefit for OA. And based on this evidence over the years, exercise is consistently included in treatment guidelines for OA from professional societies. These are just two examples. On the left, from the American College of Rheumatology. At the top, it is one of the core recommended components. And then for the Osteoarthritis Research Society International as well. In the red box, I'm showing the selection of core treatments. Exercise is included as one of those. So let's switch gears a little bit and talk about the need for these types of interventions dealing with behavior change. Again, there have been many studies in this area, and I'm going to just give a few examples, but I would say the bottom line is that there's abundant evidence that many people with osteoarthritis are not sufficiently physically active. These are data from the US-based Osteoarthritis Initiative cohort, which includes people with or at risk for knee osteoarthritis. And the overall conclusion here was that 55% of men and about 80% of women failed to achieve physical activity guidelines. In this case, this was from the US Department of Health and Human Services, defined as 150 minutes of unbounded moderate to vigorous weekly activity. So that's on that sample as a whole. And if you look at the subsamples in this slide, particularly furthest on the right is a sample with radiographic and symptomatic knee osteoarthritis. And here, the activity levels are even lower. So 39% of men and 15% of women were meeting these guidelines. And in the same study, the researchers found that there were subgroups of people who were even less likely to be meeting these physical activity recommendations. And those groups included women, people who were older, people with higher body mass index, people of non-white race, those with more depressive symptoms, people who were not working, and those with frequent knee symptoms. So these are groups and factors that we should be considering when we are both developing and targeting behavior change interventions for physical activity or exercise. So some other data have looked at healthcare provider recommendations for exercise. So we're going to talk, I think, a lot today about the patient side, the person with osteoarthritis, but I wanted to bring this into the picture because I think healthcare providers are really important in this, this whole picture. These are data from the US National Health Interview Survey, and they found that about 60% of people with arthritis report that their healthcare provider has suggested a physical activity to help with arthritis or joint symptoms. And you can see that this has increased a bit over time, is actually at the target that was set for Healthy People 2020. So not overall a discouraging message, but certainly there's some room for improvement. And just briefly here, I wanted to show that they're in the same study, they looked at different demographic and behavioral risk factor categories and whether the proportion of people reporting a provider recommendation differed. And the bottom line is they didn't too much. Most of them ranged from 50 to 70%. You can see one of the highest groups in the top right-hand panel for you is about 70% of people who were with obesity reported that a healthcare provider recommended activity to them. So bottom line here is that it seems to be pretty pervasive regardless, or pretty consistent regardless of individuals' behavioral and demographic characteristics. So these are data that look at the same question, but from the provider side. This is the 2018 US Doc Style Survey, and the data are particularly from about 1,400 primary care providers who see people, adults with arthritis. So, and then they asked these providers whether they assessed or recommended physical activity. And you can see here, 49% that they said that they always recommended physical activity, and 58%, I'm sorry, assessed, and then 58% said they always recommended physical activity. So I think this is interesting because if you think about that recommended, it's very similar to the question that was asked of patients and a very similar proportion. So that seems to be a consistent picture of what's going on in these healthcare visits. And the last data I wanted to show today, actually a study conducted by Dr. Hinman's group, was a combination of data from 3 randomized clinical trials of different exercise-based interventions for people with osteoarthritis. And they looked at this trajectories of self-reported adherence over time. Okay, so these are pooled analysis of 341 patients. And you can see here that there were some different patterns of adherence that were uncovered, but all of them were either persistently low, which is what you see in the bottom right-hand graph, or declining over time. So here what we're seeing is that even in patients who are engaged in these structured exercise interventions, it's really a challenge to help for people to maintain exercise over time. So I think this is, to me, very telling and some of the most solid evidence for what the rest of the speakers are going to be talking about today in terms of us really needing to build the science regarding behavior change interventions, including the maintenance component. So just a quick summary. We know there's strong evidence for physical activity in the context of OA and exercise. Many people with OA are insufficiently active. There are some disparities in exercise and physical activity, some people who are at greater risk for inactivity. We have room for improvement in healthcare provider recommendations for exercise and physical activity. And then, as I mentioned on the last slide, even after people are participating in formal exercise programs, adherence tends to decline over time.